The next speaker is probably very well known to this group, but he's recently changed venues. He was Mr. Whipple at Johns Hopkins and has now moved to Southwestern in Dallas, where he is chairman of the Department of Surgery. Dr. Mike Choti is going to talk about pancreatic neuroendocrine tumors. Most of the stuff that you've heard today is of the bowel, and he's going to talk about the technical aspects of what we do to take out tumors in the pancreas that are neuroendocrine tumors. Mike?
Thank you, Gene. Thank you all. Can you hear me? I'm delighted to be here. Thank you for the organizers for inviting me to be back. And I certainly seeing a lot of friends and patients and to speak to you and hopefully talk a little bit about pancreatic neuroendocrine tumor. Another area, of course, as you know, related to the neuroendocrine group. Is this where I advance the slides?
Yep.
So I have no disclosures. So as you know, neuroendocrine tumors, formerly known as islet cell tumors, that terminology we generally try not to use, but as you know, it accounts for about 1% of pancreatic cancer, although probably the ratio is going up a little bit. So patients who have pancreatic cancer, unfortunately, most are adenocarcinoma, a much more lethal variety of pancreatic cancer. But still, as you know, neuroendocrine cancer of the pancreas can still be lethal. The data suggests about half of these are non-functional. You've heard from Dr. Warner that insulinoma, glucagonoma, gastronoma are islet cell or neuroendocrine tumors. The literature suggests about half are non-functional, meaning that while they may make hormones, they're not clinically active or have a clinical impact. I would say the number of non-functional has been going up in years. In many experiences, it's up to perhaps 70% of patients who present with pancreatic neuroendocrine tumors are in fact non-functional. The functional tumors, most are insulinomas and gastronomas, but there are a variety of even very rare syndromes of hormonal type tumors. I won't spend a lot about that. And surgical resection is the principal mainstay of therapy, particularly in tumors that are locally or still remain at least apparently local. And we'll talk about the lymphadenectomy and the type of operations. PD stands for Pancreaticoduodenectomy, or DP, distal pancreatectomy, enucleation. So there are different techniques in the pancreas. So a little bit about the anatomy of the pancreas itself. This is a diagram of the pancreas. It's a digestive organ in the back of the abdomen. You can see a linear organ in the upper abdomen. Its main function is to make exocrine enzymes for digestion through the pancreatic duct. You can see going out the little valve, the ampulla of Vater, and it joins the bile duct that makes also digestive juice. Bile, they join in the head of the pancreas and come out this valve. So tumors, both adenocarcinoma and neuroendocrine tumors that are situated in the head of the pancreas can sometimes block the bile duct, resulting in jaundice, which then allows us to make the diagnosis even in a non-functional tumor. A tumor that blocks the pancreatic duct really doesn't cause typically symptoms, although symptoms of exocrine insufficiency, so-called steatorrhea or digestive problems, diarrhea related to lack of pancreatic digestive enzymes, can perhaps cause symptoms, but it's pretty non-specific. Although, as we'll talk about, sometimes on the scan you can see a dilated pancreatic duct, which is a symptom of or a finding of the obstruction of the duct. So we'll talk about the different approaches. Clearly, surgically addressing the pancreas depend on the location within the pancreas. The head of the pancreas is near the duodenum there. The neck, the body, the tail, so the terminology. And you can see the relationship with the bile duct and the relationship with the duodenum. Parenthetically, we're not really spending time talking about carcinoid tumors of the duodenum, but that's another entity that I'm seeing more frequently. And that the management, the biology may be similar to midgut carcinoid tumors. They can present as carcinoid tumors, but the management, the surgical management, is often similar to that of neuroendocrine tumors of the pancreas. That is, the operations may be similar. So what are the surgical approaches? As I mentioned, the most common are for cancers in the head of the pancreas, the Whipple operation or Pancreaticoduodenectomy, the distal pancreatectomy, and we can talk about whether to include the splenectomy with it for tumors and typically in the body or tail. There are, in some cases where there's multifocal disease, the whole pancreas can be removed. One can imagine that one still needs exocrine replacement, and often these patients can be diabetic, of course, so need careful control of diabetes if the whole pancreas is removed. So what I failed to mention, so the function of the pancreas, one function is the exocrine function, as I mentioned, making digestive juices. The other function of the pancreas is the endocrine function, most commonly making insulin. So if the whole pancreas is removed, the patient then, of course, is diabetic. In neuroendocrine tumors, where we're not concerned about removing the lymph nodes as much than the so-called tumor enucleation, just kind of carving it out as an option, there's also some central pancreatectomy, which is another uncommon operation. In any of these operations, even a Whipple can be done laparoscopically or open surgery or even robotic surgery in selected cases. The Whipple operation, named after a guy named Alan O. Whipple, a surgeon from the US. You can see here if the history of this pancreaticoduodenectomy actually dates back to 1909 by a German surgeon, Walter Kausch, but really, and then another German surgeon in 1914, and others described this operation. But really, not till 1935, Alan O. Whipple, an American surgeon, reported a small series, and for some reason, his name kind of was associated with this operation. Then over the many decades, this was felt to be a ridiculous operation because of the extremely high mortality related to removing the head of the pancreas and the part of the duodenum and so forth. So it was really an operation that was condemned, frankly, for decades until really the 60s, 70s, and even 80s, particularly for cancer, for aggressive cancer such as adenocarcinoma, but even for neuroendocrine tumors. And now we've gotten much better at doing this operation, much lower morbidity and mortality. And so now it's a fairly common operation for any form of cancer or even benign tumors in the head of the pancreas. This is a cartoon of the plumbing, if you will, the reconstruction. You can see on the left is a diagram of a tumor in the head of the pancreas, and those lines there are where they can be cut. This is a diagram of so-called pylorus preserving pancreaticoduodenectomy. The pylorus, I don't know so the pylorus is the structure over here on this diagram, but the pylorus is over here, this little valve between the stomach and the duodenum, so that part can be removed or not, depending. The duodenum is removed, and then this is how it's reconstructed. You can see the connections here between the pancreas and the intestine, the bowel, and the bile duct. You can see the reconstruction here on the right side. So that's the Whipple operation. Fairly commonly done. It's about a 4 to 6 hour operation. Most patients are in the hospital about a week, something like that. It can be done open or laparoscopically. Very important in assessing the tumor location and determining if it's operable or not, and what the operable technique is imaging and cross-sectional imaging. This is a CT scan, very important to assess the relative location of the tumor to vital structures in the area. In this case, the main artery and main veins to the intestine and the liver, the superior mesenteric artery, portal veins, and other vessels. So the proximity of these structures, based on whether there's a plane between those vital vascular structures and the pancreas, determine resectability, operability, and whether it can be safely removed. In selected cases, we may remove or reconstruct these veins or arteries, or give treatment prior to surgery to try to shrink it in order to increase the safety or operability when doing these complex operations. Fortunately, if you look, these are data looking of a series actually from Johns Hopkins looking at pancreaticoduodenectomy, Whipple, in patients with pancreatic cancer. And you can see these curves just show that the prognosis following a Whipple for neuroendocrine, pancreatic neuroendocrine, is very different than that of ductal adenocarcinoma. This is the survival curve for the more common pancreas cancer, and this is another variety. Look at the 5-year survival of pancreatic adenocarcinoma after a successful complete removal, if you will, with a Whipple, is still about 20% 5-year survival, quite poor compared to neuroendocrine, where here we're seeing in the 70 to 80% cure rate, if you will, adenocarcinoma compared to neuroendocrine, pancreatic neuroendocrine. One important thing with the Whipple operation, and indeed most complex operations, experience of the team, the hospital, and the volume, at least as a surrogate for experience, does reflect improved outcomes, at least in the short term. These are data looking at by the volume of operations of Whipples done by hospital, looking at just the intraoperative mortality rate, dying from complications of surgery. And you can see, for example, here on the left for resections, in a low volume hospital, the mortality rate for this operation was close to 20% mortality in hospitals that just do 1 or 2 a year, compared to the high volume hospitals where the mortality rate is in the 1 to 2% range. So this is just a statement, not to just, you need to make sure that you go to an experienced team. It's not all about the surgeon as well. It's more about the volume of the hospital, the ICU, the nursing, the pathology, all of the aspects of a high volume experience center reflects in at least short-term improved outcomes. And there are data to emerge that even the oncologic outcomes, the long-term survival, also is a function of the experience of the team. This is just a cartoon of the distal pancreatectomy. So tumors, neuroendocrine tumors in the body or the tail of the pancreas can be safely removed by removing the left half of the pancreas, an easier operation, a couple of hour operation. Sometimes the spleen, often the spleen is removed with the distal pancreas. You can see how close the spleen is to the tail of the pancreas. Important not only because, as in this picture, this resected specimen where the tumor in the tail of the pancreas is actually invading into the spleen. Of course, the spleen needs to be removed in that case, but often the lymph nodes around there necessitate the splenectomy to do an adequate cancer operation in some cases. Although small neuroendocrine tumors of the body or tail of the pancreas can be removed with a so-called spleen-preserving distal pancreatectomy, which we do in some cases. This operation is more commonly done laparoscopically, and it's fairly safely. So I would say in most cases, 8 out of 10 cases of distal pancreatectomy, at least in our center, is done laparoscopically, and now more and more even being done robotically. The data on the benefit of laparoscopic versus open versus robotic, some of it is driven by market pressures and other things. It's hard to really know whether these operations necessarily are better, but it does seem like at least laparoscopic distal pancreatectomy is done with a shorter hospital stay, shorter time to return to work, safe oncologic parameters, and probably in many cases is the preferred approach, although it really depends on the skill set of the individual surgeon. Parenthetically, the laparoscopic or robotic Whipple operation, gaining subtraction in some centers, probably it's a fairly difficult learning curve. It's associated with fairly high morbidity, and I think the jury is still out as to whether laparoscopic Whipple is really the way to go, at least in 2014, 15, but probably as technology gets better, that we may be doing more minimally invasive Whipple operations as well. Enucleation, I mentioned, selected cases, small tumor where it's on the surface of the pancreas, one can kind of get the 9-iron out and just kind of chip it off the green there, just kind of shell it out and then manage it that way. These can still leak pancreatic juice, one still needs to be careful, and it's really, we're not doing a lymphadenectomy, which we don't always need for smaller ones, but in selected cases, often insulinomas or small surface tumors, this is an approach that's used occasionally for pancreatic neuroendocrine tumors. I mentioned laparoscopic approach, certainly with a distal, this is a favorable approach. One could see here a cartoon, you could visualize the tumor, and the operations are performed fairly straightforwardly. One interesting point is that, as I'll mention, more and more of these non-functional pancreatic neuroendocrine tumors are being found incidentally and are small. And so often we use intraoperative ultrasound to find the location or to feel the pancreas to know where the tumor is to be able to remove it. With a laparoscopic approach, you can't really feel, and so this can sometimes be a challenge to know where to divide the pancreas and to make sure that the small tumor is included in it. This is actually an approach that we and others have described tattooing the pancreas, believe it or not, prior to a distal laparoscopic approach. So this is using endoscopic ultrasound through the stomach. You can see this drawing here to image the tiny 5-10 millimeter tumor, and then to put a tattoo on the pancreas, usually just proximal to it. So laparoscopically, you can see here, you can see the tattoo and know that that's going to, if you divide it that area, you can incorporate. There's the specimen, the tumor, and the tattoo next to it. So another approach using the preoperative marking to be able to do a safer, minimally invasive operation. As I mentioned, more and more now in pancreatic neuroendocrine tumors, yes, many patients present with metastatic disease, some do, but more often than not, we're finding incidental small tumors, and the question is really what's the optimal management. Here's a case presentation, 58-year-old office manager. She had symptoms of abdominal pain, CT scan showed diverticulitis, and she was treated for diverticulitis with antibiotics. It got better, but oh, by the way, a small enhancing tiny tumor was found in the pancreas just incidentally on the CAT scan. We're now getting CAT scans or MRIs for a whole variety of reasons, and often they'll pick up little incidental things, including small neuroendocrine tumors of the pancreas. She has no history, no symptoms, referred for evaluation. Here's actually the finding, a tiny little enhancing tumor. This is in the head of the pancreas near the main blood vessel, the vein there. And so one question is, what to do about it? What's the prognosis? So this patient, it would be difficult to enucleate. This may be a Whipple, possibly a Whipple required to take this out. What do you do with a 5 millimeter tumor? We don't really know. You wait, we heard our last talk, surgery, 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 be aggressive, but it's possible that this tiny little thing, very unlikely to be in nodes, found incidentally, does one really subject a patient to a radical pancreaticoduodenectomy for a 5 millimeter neuroendocrine, non-functional neuroendocrine tumor of the pancreas? The short answer is we don't know. I must say we're looking at data on this and suggesting certainly over a centimeter, the risks start going up for developing metastases in the future. So we're still learning about the biology of these and probably better markers than just size. We heard about Ki-67, we heard about there may be better biologic markers to predict whether the biology of a small tumor like this is destined in this woman's lifetime to metastasize or not. It's a little easier in ileal or in other tumors where one can make an argument, if in doubt, just go ahead and take it out. But to subject someone to particularly if it's a fairly radical operation, more radical operation, then there's still some controversy as to the optimal management for these. In fact, it's very interesting with these neuroendocrine tumors of the pancreas, it's not even a mass that's often detected, but a dilated duct. And much like carcinoid tumors, where there can be some local hormonal factors that cause fibrosis in the mesentery, sometimes we see this fibrosis action in even pancreatic tumors in the body of the pancreas that elicits a stricture or a narrowing of the pancreatic duct, even when the mass itself is not blocking the duct, if you will. And we described this in a paper published a few years ago, a local narrowing of the duct just from an inflammation, if you will. Finally, let me talk about metastatic pancreatic neuroendocrine and including to the liver. This is an area obviously we see. You heard a little bit about the controversies with regard to surgical therapy for metastatic disease, debulking, liver resection, and so forth. There are a variety of local regional approaches, Y90, chemoembolization, surgery, ablation, and so forth, that we approach just like we do with metastatic carcinoid tumors to the liver. We use similar approaches for metastatic pancreatic neuroendocrine tumors to the liver, although there are some differences and some caveats that we may need to think about. This is a study we published decades ago, very small series suggesting, yeah, we should be doing liver resection for metastatic neuroendocrine tumors. This, of course, a retrospective cohort study suggested resected versus unresected. And there have been dozens and dozens of non-controlled studies suggesting a benefit of surgical therapy for metastatic neuroendocrine tumor. In fact, a more recent study we did looking retrospectively at over 300 patients undergoing liver-directed therapy for metastatic neuroendocrine tumor suggests it's still perhaps somewhat more controversial. I still advocate an aggressive, of course, surgical approach for metastatic disease, but it's still somewhat controversial. In this study, 34% of these metastatic, this included both carcinoid and pancreatic neuroendocrine, about majority had bilateral disease. You can see most underwent resection, and 78%, 80% had complete removal of all, at least the visible disease, so-called R0, R1. About 22% had residual disease left behind, visible disease left behind in the liver. You can see in this study, half were carcinoid, and this is the survival rate, 82% 3-year survival, about 50% 10-year survival, and so forth. But what's interesting is these are the Kaplan-Meier, the survival curves in this long-term study of resected, removed liver metastases for neuroendocrine tumor. You can see it's interesting. When they were hormonally active, is in the black, versus non-functional, which is in the red. And you can see the complete resection, R0 or R1, really didn't have a different survival than the ones where residual disease was left behind. So one can interpret it, at least for the non-functional, can interpret it one of two ways: either that it makes sense to go ahead and resect and leave disease behind, or you can look at the opposite. It didn't make any difference if you got all the visible versus left some behind. So hard to know, but certainly I think there's a reason to advocate aggressive surgical approach, but one still needs to approach this cautiously. It's still a challenge because it's difficult to do randomized studies on the benefit of such approaches. One interesting thing in neuroendocrine tumors in general is it's not uncommon to have metastatic neuroendocrine disease in which we don't even know where the primary is. As you heard about, often the primary can be small, and so often patients will present with liver metastases. Biopsy shows neuroendocrine, unknown primary. So it's interesting. We looked at this question in over 100 patients. 73% metastatic of liver resection, 73% of patients, the primary was found preoperatively with good imaging, scanning, nuclear medicine imaging. Of these, interestingly, and at least in our series, 57% were pancreatic, 57% were carcinoid. So about half and half, the primary was in one of those two locations. Among those that were the 20% which we could not find the primary preoperatively and still went to surgery, 18%, interestingly, the primary was found operatively in almost all those cases, most of those cases, most were carcinoid. No surprise. Imaging of the pancreas is good. It's harder to image these tiny primary tumors, easy to find them intraoperatively. So the majority of the primaries were found in these, and most were carcinoid tumors. Interestingly, among the small fraction, in this case 9%, no primary found even at the time of surgery. Those patients were followed up, very small number in this series, but interestingly, about half over the next 5 years, the primary popped up eventually. In our experience, 2/3 of those, a small number, were in the pancreas. So a tiny tumor 5 years later pops up in the pancreas. So interestingly, it's an interesting question of how to identify the primary tumor in these selected cases. Another important caveat with regard to surgical therapy, specifically of the liver-directed therapy in pancreatic neuroendocrine tumor, is the issue related to the Whipple combined with the liver resection. So if a patient presents with metastatic disease in the head of the pancreas and liver metastases, one needs to think about doing a Whipple operation and liver-directed therapy, whether that's surgical therapy, resection, or ablation, or Y90, or any liver-directed therapy. And one interesting phenomenon has been well described, and that is a complication associated with a Whipple. And that is when a Whipple is done, the bile duct is reconnected in a way, as you saw in the earlier diagrams, in which the bile duct is connected directly to the intestine without that valve in between. So what happens is the liver is naturally now colonized with intestinal contents, different than in the normal situation. The problem is when then, after a Whipple, liver-directed therapy is done, including surgery, very high risk of liver abscesses or liver infection. So this is an issue one needs to think. It's specific, mostly specific to neuroendocrine, because it's rare we operate on metastases of the liver from pancreatic adenocarcinoma, but it's a common phenomenon in neuroendocrine of the pancreas. And in fact, we looked at this. This is a study just suggested that if you do a Whipple and liver resection at the same time, the infection rate, in this case, you can see the liver abscess rate was 5%, where if you did the Whipple first and then the liver direct, these are patients where it presented at the same time. If you did the liver first, or the Whipple first, and then the liver, you had a higher abscess rate, in this case 15%, and a very high complication rate. I would say that even if you do the Whipple and the liver at the same time, the infection rate, the complication rate is still higher than if you did it the other way around. So more and more now, I'm doing a liver first strategy in patients that present with both. So we'll do the clear the liver and then do the Whipple, for example, at a later date. So finally, just to touch on one thing, and that is the future is really identifying biomarkers to know how to manage these patients rather than using crude staging information. And we were using Ki-67 and other approaches, but can we use new molecular approaches, genomic sequencing and other molecular approaches to try to get smarter about what's the right way to manage our patients with neuroendocrine cancer. One study we did is looking at this unusual phenomenon called lengthening of telomeres, and showed some interesting results in pancreatic neuroendocrine. Telomeres, you may know, it's the end, it's kind of the ends of the shoestrings, if you will, on your shoelaces that provide like caps on the end of the chromosomes. And the interesting biology is that the way the normal mitotic clock in cells result in the telomeres get shorter and shorter with every cell replication, so every cell has a natural lifespan. And one of the most common mechanisms of how a cancer gains long-term immortality is by preventing the telomeres from shortening. In fact, we think probably aging is related to your body cells, the telomeres shorten over time. And so the telomerase is an enzyme in which cancers often use to overcome that and gain immortality. 85% of human cancers use telomerase activity as a way to bypass the mitotic clock using the telomere strategy. But there's an alternative approach, the so-called alternative lengthening telomeres. And without going into that, pancreatic neuroendocrine tumors are one of the few tumors that use this alternative approach for gaining immortality. They don't use telomerase mutation. And so we thought, could we capitalize on this? And this is using fairly straightforward molecular studies of biopsies or of tissue to try to look at neuroendocrine tumors to see whether they have this unusual unusual molecular signature that can help us assess a variety of things. It's also, by the way, associated with this ATRX-DAXX mutation that may be associated with both with pancreatic neuroendocrine, but also perhaps with susceptibility to certain systemic therapies, or like everolimus and so forth. So it may have some other benefits. With regard to surgical barriers, we found this interesting. If you look at the management of neuroendocrine metastases, particularly in the liver, three very important clinical questions we thought we would try to answer. One is, as I mentioned, determining the origin. If you don't know if it's for carcinoid or pancreatic, could you use this to help predict? Second, we saw some patients have this miliary pattern and some have more oligometastatic pattern. The oligometastatic pattern isn't always detected on a scan because the little ones are sometimes small, but certainly surgical therapy is generally more favored if a patient has more oligometastatic than miliary metastatic. And perhaps we could look at that. And the other is biomarker, as I mentioned, of prognosis. Interestingly, this altered ALT helps us in all of these areas. So as far as the unknown primary, if you can see, for example, in this study, if you look at patients where you don't know where the primary is from, if they have this altered ALT, 50% of them were pancreatic. But more importantly, if they had negative ALT, they were almost all carcinoid. So at least helpful if one looks at this tumor marker on a biopsy. This can help then tell just with a biopsy whether it's carcinoid or whether it's pancreatic neuroendocrine. And that can have some bearing in how to manage it, looking for the primary, whether to give certain systemic therapies before or not. The other is this miliary pattern. Indeed, it suggested that ALT-positive neuroendocrine liver metastases were more likely oligometastatic, and those where it was less likely bilateral. If they're ALT negative, they're more likely to have that miliary pattern. So again, such a biopsy can help assess whether a local approach may be better and more likely to achieve a margin negative resection. And finally, prognostically too, the ALT-positive tumors were associated with a better prognosis than ALT-negative tumors. So another biomarker, much like Ki67 or mitotic rate, that we can add to the armamentarium to profile cancers to know prognosis and perhaps a biomarker for best therapy. So in summary, with regard to surgical management of pancreatic neuroendocrine tumors, still certainly surgical resection, certainly for local regional disease, is absolutely the treatment of choice, but even in metastatic disease, often it is. The approach depends, of course, on the location as well as the size and other things. The management of tiny incidental non-functional neuroendocrine tumors remains controversial. Resection or ablation of metastatic disease, certainly when all the disease can be treated, visible disease, is still generally the treatment of choice. One needs to think about this issue of the sequencing of a Whipple versus addressing the liver because of infectious complications. And finally, new molecular biomarkers such as ALT may help us in the future to try to do better for our patients and improve our outcomes and hopefully cure this disease. I thank you very much for your attention.